I'm going to present a topic titled Locally Advanced Breast Cancer. I'm sure many of you know something about it, all about it. It is just a reminder of what you already have. Most cases of stage 3 breast cancer were once stage 1 breast cancer. In poor countries, more than half of patients have locally advanced or metastatic disease at the time of diagnosis. Lack of education and lack of screening are the causes of this delayed presentation. The clinical presentation is very grave and very serious, as you will see later, in the form of skin ulceration, skin edema, tumor fixation to the chest wall, axillary nodes larger than 2.5 centimeters, fixed axillary nodes, satellites in the skin, satellites, nodules, and infraclavicular internal memory, and supraclavicular adenopathy. All these are late presentations of locally advanced breast cancer. These are the examples: PDRI, and this bulging mass, ulcerating one, and as you see, it's a very late presentation, and it was really a dilemma before the advent of chemotherapy. You just do very minor surgery and it recurs again very quickly. You have to do a diagnostic workup in the form of to distinguish between benign and malignant disease, distinguish invasive and non-invasive disease, obtain pathological diagnosis before treatment, and the best is percutaneous image-guided biopsy because the mass is big and the malignant part is usually a small focus, and unless you guide the needle by an imaging technique, you tend to miss the malignant part, and the result is false negative. Core needle biopsy, fine needle aspiration is not commonly used in advanced disease, and simply because if you need neoadjuvant treatment is not given with the result of fine needle aspiration. Other ways of diagnosis, excisional biopsy if it is excisable, and the commonest is incisional biopsy. When we say locally advanced disease, we mean the following in the TNM staging system. TN are involved in this advanced disease. Any tumor, T3 or more, that is any tumor more than 5 centimeters, is locally advanced tumor. All T4 tumors, A, invading the chest wall, B, invading the skin, C, invading both, D, inflammatory carcinoma, all these T's are locally advanced tumor when we talk about it. In lymph node status, any tumor with N2, A, involvement of 4 to 9 axillary lymph nodes, N2B, involvement of only internal memory lymph nodes. This is also locally advanced. N3, involvement of 10 or more axillary lymph nodes, that is N3A, or the infraclavicular nodes. N3B, involvement of the internal memory nodes and axillary. N3C, involvement of the supraclavicular nodes, and this N3 previously was M1, but a few years ago it has been changed to N3 instead of M1. Staging, local advanced is at least it is 2B and 3A with all its formations, and 3B and 3C. Stage 4 is usually not locally advanced. This is metastatic disease, but involvement of bone, 1 or 2 foci, do not prevent local treatment. Survival according to treatment, surgery alone for this local advanced disease, 5-year survival 36%, and radiation only 29%, surgery plus radiation 33%, chemotherapy, surgery and radiation 63%, and really there is a very dramatic change. The goals of the systemic treatment is to attain cure, prevent recurrence, eradicate micrometastasis. The systemic treatments available are chemotherapy, hormonal therapy, tamoxifen and aromatase inhibitors, and monoclonal antibody therapy or targeted therapy, and supportive care. The chemotherapy for breast cancer improves disease-free and overall survival. Durations of more than 6 months do not add major advantage. Anthracycline-based combinations are better than combination of cyclophosphamide, methotrexate, and fluorouracil. Taxane-based combinations are more effective in the adjuvant setting. Trastuzumab or Herceptin in the adjuvant setting improve disease. Herceptin is very promising in the future, inshallah. The concept of neoadjuvant chemotherapy is developed concurrently with adjuvant chemotherapy in the 70s. Treatment for locally advanced breast cancer stage 3 disease allows for immediate assessment of tumor response, allows for the evaluation of new and novel agents. The goals of the neoadjuvant is to decrease the size of the tumor, to minimize surgery. Instead of total mastectomy, you can suffice yourself with breast conserving surgery and establish tumor sensitivity. Appropriate treatments are chemotherapy for those who are fit and can tolerate, and they haven't got comorbidities preventing chemotherapy. For those who are ill and who cannot tolerate chemotherapy, hormonal therapy can be given as a neoadjuvant. If all these fail, chemotherapy and hormonal radiation therapy, although it is not a systemic treatment like it can help reduce the size of the tumor in some patients and allow surgery to be done. The clinical rationale for preoperative chemotherapy, excellent response rates for locally node-negative breast cancer, equivalent survival for breast cancer mass became smaller in size, and you can do breast conserving surgery. It is equivalent in its benefits to the total mastectomy, and this is really a great achievement. Neoadjuvant chemotherapy increase the rate of breast conserving surgery, early treatment of macrometastasis. Treatment serves as in vivo chemosensitivity assay, improved rates of local control and disease-free survival. Indeed, before the advent of this chemotherapy, local advanced tumors were only operated upon in the form of what is called toilet mastectomy, which is just removal of part of the tumor to facilitate closure of the skin, to reduce the morbidity in the form of ulceration and improve the quality of life, and it soon recurs and comes back, and then you wait for the patient to die. But after neoadjuvant chemotherapy, definitely a lot of things change. Prognosis of locally advanced breast cancer based upon pathological response to neoadjuvant chemotherapy. If after neoadjuvant chemotherapy, the lymph nodes are negative, 5-year survival is 75%. If 0 to 4 positive lymph nodes, 1 to 4, 50 to 50, 40 to 50%, 5 to 10 positive nodes, 30%. And the problem is chemotherapy, neoadjuvant chemotherapy and adjuvant chemotherapy, the response of patients is not all the same. Patients differ in their response. Some people from the first and second sessions, they improve and the mass disappears. Others, you give them 6, 8 sessions and give them line 1, line 2, line 3, and they don't respond. This made pathologists and oncologists think that breast disease is not a single disease. The same grade, the same size, the same age and sex, We give the treatment, some respond, others do not. Neoadjuvant treatment increases the likelihood of breast cancer acceptable to women with inflammatory breast cancer. In inflammatory breast cancer, even if the tumor disappears completely, the treatment is total mastectomy, and there is no place for conservative or breast conserving surgery in inflammatory carcinoma. Factors influencing decision to use neoadjuvant chemotherapy in operable breast cancer. First, does the patient need adjuvant chemotherapy based on information known prior to surgery? Sometimes local advanced tumors are small, and even without neoadjuvant, you can operate on them, either remove the breast or do wide local excision. And so, if it is not needed, you don't need to give it. Would neoadjuvant chemotherapy potentially alter the extent of the resection? هل تغير الديسيجن بتاعك؟ Does the patient desire breast preservation? Yeah, some patients they tell you remove the breast, I don't want it. So there is no need to give them chemotherapy if you can remove it without neoadjuvant. Would treatment benefit from knowledge of in vivo chemosensitivity? The response depends on the size of the tumor. Malignancies, chemotherapy is effective if the tumor is small, more than the larger the tumor, the smaller the percentage of response. It is logical because if you reduce the load of the malignant cells, chemotherapy, hormonal therapy are effective because they act on a small volume of malignant cells. The clinical response, complete response in some trials, response to preoperative chemotherapy, 36% complete response, partial response, 43, stable and progressive disease, 20%. Positive notes in postoperative chemotherapy, 58%, and preoperative is definitely better, 40% only. And lumpectomy rate is greater with preoperative chemotherapy neoadjuvant than in postoperative chemotherapy, and cumulative incidence, breast cancer recurrence, seem they're not far apart from each other, postoperative and preoperative, they look like each other. Survival is almost the same in both. Compared with chemotherapy and surgery alone, chemotherapy and docetaxel followed by surgery led to increased rates of clinical response, pathological response, downstaging of node disease, and lumpectomies. Taxane is a new drug, and the development is going for inventing new drugs, which will definitely have. This drug is very effective when added to other drugs and facilitate surgery. And as you see, the clinical response is better, pathological response is better, downstaging is better, lumpectomy rate is increasing. Clinical response, patients, if you give Taxel, 26%, clinical number of patients, 85%, 85% in those without Taxel, and 91% in those. It's a difference. Pathological complete response with Taxel. It is almost twice the effect. Taxel. Taxel is really a very effective chemotherapy and surgery followed by Taxel, as you said. Neoadjuvant Taxel trial by Aberdeen, randomized trial, single agent, and compared with anthracycline-based polytherapy. And the final result is that Taxel response of patients with taxane is better than poly therapy, and nowadays it is used previous cytotoxics. Now, in addition, hormonal and monoclonal therapies, this is monoclonal or targeted therapy. This is really a very promising discovery, and it usually attacks the malignant cells only and does not affect the healthy cells. And really showing very great promise. Still, trials are going on, but the drug is very expensive and you need to continue for a year or more. But it seems that the future is for such monoclonal therapies or targeted therapies which only attack the disease cells and does not affect the normal cells. Update on studies with trastuzumab or Herceptin اللي هو targeted therapy, survival advantage with chemotherapy and trastuzumab in the metastatic setting added to adjuvant setting produces spectacular results with 50% decrease in recurrence. Alternative approach is to introduce trastuzumab with the neoadjuvant setting where response to therapy can provide an intermediate endpoint for the impact of Herceptin on survival in early breast cancer. Really, if you give it to neoadjuvant, it seems to improve the outcome very greatly. Hormonal therapy, tamoxifen is an old one, estrogen and progesterone. These are early drugs discovered because some tumors are hormone dependent, and if you change the environment, you tend to destroy the malignant cell. And recently, aromatase inhibitors, they suppress the ovaries, are introduced and are far more effective than estrogen receptors, drugs, tamoxifens. As we said previously, if chemotherapy is not possible because of the morbidity of the patient, cannot tolerate it, endocrine therapy can really produce good effects in some patients. As you see in these mammograms, before treatment, the lump is there, as you see in the upper left corner, and after treatment with letrozole, which is a hormonal therapy, the mass almost completely disappeared. Neoadjuvant tamoxifen compared with letrozole is more effective than tamoxifen, and it is now taking almost the place of tamoxifen. Neoadjuvant tamoxifen compared with letrozole, breast conserving surgery, as you see, letrozole is greater in all sizes of the tumors and in overall results. Radiation therapy after mastectomy, according to consensus statement developed by American Society for Therapeutic Radiology and Oncology, radiation therapy should be part of the treatment for stage 3 breast cancers and for diseases that involves 4 or more lymph nodes in the axilla. At a minimum, the chest wall and the supraclavicular fossa should be treated with doses of at least 50 GOI. Previously, radiotherapy is given only when you do breast conserving surgery, and it is mandatory in that. But in tumors, local advanced tumors, even if you remove the breast, radiotherapy. The idea behind that is that there are internal mammary lymph nodes which cannot be detected easily by all available imaging techniques, and you presume in local advanced disease they are involved. So at least after you remove the breast, you give radiation at least to kill any malignant cells in these invisible lymph nodes inside the chest. Inflammatory breast carcinoma is one of the local advanced tumors, and really it is a very the worst of all. Rapidly progressive tumor with high propensity for early metastatic spread. It is the most lethal form of all locally advanced breast cancer. Patients typically present with pain and rapidly progressive, tender, firm, enlarged breast. And many times, the patients are treated as mastitis or breast abscess and given antibiotics. And really, it is different from other locally advanced disease. It is different from locally advanced disease for many reasons. Inflammatory breast clinical diagnosis is the mainstay of diagnosis. Imaging and pathology are not conclusive in most cases. Inflammatory breast cancer treatment protocols, order of treatment, and then questions. Inflammatory breast cancer has been described for 20 years. First described in 1814 by Sir Charles Bell as a purple color or the skin of the tumor accompanied by shooting pain. The term inflammatory breast cancer was proposed by Lee and Transbaum in 1924 after this disease had many previous names: lactational cancer, carcinoma mastoiditis, mastitis carcinomatosa, acute encephaloid cancer, acute mammary carcinoma, acute bronchial cancer, acute squamous carcinoma, and carcinoma telangiectasium. These are named descriptive of the condition, showing it is from the normally locally advanced. Diagnosed clinically, no current molecular definition. 2 to 5% of total breast cancer incidence, but 10% of the mortality. There are two types of inflammatory breast cancer. Primary, developing in a previously normal breast in most cases. Secondary, features of inflammatory breast cancer and biopsy-proven invasive cancer on the chest wall post-mastectomy for non-inflammatory breast cancer. After surgery for cancer, not inflammatory, there may appear signs of inflammatory breast cancer as seen by invasion of the lymphatics. Or recurrence with inflammatory features in a breast that already had cancer. A palpable lump is present in only 1/3 of inflammatory breast cancer patients at diagnosis. Hence, the Inflammatory Breast Cancer Network slogan, "No lump is still cancer." When we say red, of course, we mean white people. In our situation, probably you will not see this red color. But anyway, it has got the features of mastitis. Inflammatory breast cancer visual symptoms are distinctive. Classical signs: warm, rapidly enlarging swollen breast due to the blockage of lymph vessels with tumor clumps, redness, covering at least 1/3 or more of the breast with a history of no more than 6 months. Neglected non-inflammatory breast cancer can invade skin and appear like inflammatory cancer. Pseudo-orange appearance of the skin overlying the breast. Breast can be painful, hence the confusion with inflammatory problems. Nipple changes may be retracted, may be flattened, may be crusted, and it may look normal. Note, not all these symptoms must be present for a diagnosis of inflammatory breast cancer. Not necessary. These are some of them, and you may not find them all, but still you can diagnose inflammatory breast cancer. No palpable lump in 2/3 of women frequently. Wavy appearance is just cloudy appearance. Mammograms miss more than 50% of inflammatory breast cancer cases. Key observations include skin thickening, stromal coarsening, diffusely increased breast density versus calcification or discrete lump in most breast cancers. High rate of abnormal enlarged lymph nodes in axilla or supraclavicular region, most easily detected by ultrasound. Information from natural data, the age of inflammatory breast cancer is younger than non-inflammatory breast cancer patients. Black and Asian women are diagnosed younger. 15 to 20% occur in women with a family history of breast cancer like the rest. It is different because it presents and behaves differently. Must be aware of symptoms and rapidly changing breast appearance. It is more difficult to detect by routine imaging. Often present in young women prior to the recommended age for beginning screening mammography. Requires multidisciplinary specialty care by experts. Mind you, although it occurs in the young, still it can occur in postmenopausal ladies. The clinical diagnosis depends, as the international expert panel on inflammatory breast cancer consensus statement, depends on the clinical findings we mentioned earlier on, and punch or true cut biopsy showing invasion of the lymphatic. The combination of the two will give you the diagnosis. Diagnostic mammogram may not observe a lump. Only 44% of inflammatory cancer detected on a mammogram. Most common finding is skin thickening, ultrasound of breast and nodes, MRI, metastatic workup, PET, and CT scan. Inflammatory breast cancer must be confirmed by a core biopsy so that enough tissue is obtained for biomarker analysis, ER, PR, and HER2. Recommended at least 2 skin pulse biopsies to determine presence of lymphovascular emboli. Try to sample the areas that are most discolored, and then you have to do testing ER, progesterone, and HER2. Examples of ER and staining patterns and hair staining. Inflammatory breast cancer is not a histological, not like the different types of encephaloid, medullary, and this thing. It is not a histological subtype of breast cancer. Pathology report may not state inflammatory breast cancer, since pathologically it is not possible to differentiate inflammatory cancer from invasive ductal carcinoma, lobular, mixed ductal, lobular, medullary, small cell, large cell, plus invasive breast cancer in the setting of the clinical symptoms described previously. So it is not an entity histological type alone. Histology invasive, it could be lobular, it could be ductal, but in the context of the clinical theory, emboli and inflammatory staging usually established American Cystic criteria for breast cancer, TNM, and it is T4D. It is T4D. Similar to breast cancer as a whole, inflammatory cancer can be ER, PR, or HER2 positive or negative. But inflammatory cancer usually is less positive than non-inflammatory cancer. And usually negative tumors are considered to be of bad prognosis than those with positive hormonal receptors. Inflammatory breast cancer metastasis is characterized by a high rate of recurrence. By 5 years. Early spread of tumor cells via lymphatics and secondary via the blood. Two types of recurrences, local and distant. Inflammatory versus locally advanced, more bone and soft tissue in the inflammatory breast cancer than in the locally advanced. Other visceral metastasis similar to non-inflammatory. The visceral is the same, but bone and soft tissue is more common in inflammatory breast cancer. But metastasis in the bone, 1 or 2, will not prevent local surgical treatment because usually they disappear with the neoadjuvant treatment. The protocol for treatment of inflammatory breast cancer, the consensus treatment strategy, first, systemic therapy, chemotherapy, plus or minus hormonal or targeted therapy for 4 to 6 months or until maximal response. If not operable, further chemotherapy. They have got part 1, part 2 degrees of chemotherapy according to strength. Further chemotherapy if there is no response, and then if there is a response, you go for modified rectal radical mastectomy, and then chest wall regional nodal radiation, as we mentioned earlier, and then you give adjuvant treatment after that. So chemotherapy first and hormonal therapy positive. If no response, then you give another line of chemotherapy, sectional clearance, and then chest wall radiation. This is the protocol for treatment. Inflammatory breast cancer, actually all cancer is considered to be systemic at diagnosis. Any palpable tumor is considered to be systemic. And hence, the giving chemotherapy even to T1 and T2 tumors, these are now trials going on because they consider any palpable breast tumor is systemic. After surgery, patients should continue tranzumab or Herceptin for a total of 1 year. It is a very expensive drug, but it is very promising to improve an outcome of the result of surgery. A local regional treatment, radiation, we give it post-mastectomy, and patients should be discouraged from using creams that have sunscreen. Those used for sun tanning. Adjuvant treatment. Is there a link to BRCA 1 and 2 mutation? Should inflammatory breast cancer patient be tested for one of these patients? They are not different. They're just like a local advanced tumor. Can men get inflammatory breast cancer? The answer is yes. There is not a large literature, but at least 0.5% of male breast cancer is inflammatory breast cancer. So it can occur in male, it can occur in post-menopausal patients. What to do for chemo-resistant disease? Is there a role for anti-angiogenic therapies, recurrence prevention strategies, in stages, peptide vaccines, statins? Of course, if you give neoadjuvant chemotherapy and they don't respond, the oncologist usually gives them radiation. And luckily, a lot of patients who do not respond to line 1, line 2, line 3, they responded to radiotherapy and surgery was made possible. Can you look at my biopsy and tell me if I have inflammatory breast cancer? Without, unfortunately not. Your doctor should use the clinical criteria. As we said before, just looking at the histology will not diagnose inflammatory breast cancer. It should be associated with clinical information as mentioned earlier. And actually, any pathologist will not be able to diagnose clinical problems unless there is clinical data, sufficient data, because there is a lot of similarities between diseases, and the clinical information we give will help the pathologist go this way or that. Can we get inflammatory breast cancer on both breasts at once? Yes, that is possible, like other types of breast. Can recurrence of inflammatory breast change hormone receptor status? Yes. Like other cancer, after sometime the tumor changes the receptors. If it's positive, it may become negative, and vice versa. The skin over the breast is warm, thickened, with a brawny duration. This info and purity, right? And this information should be given to the pathologist with the specimen. The skin color, as you said, it is pink in white people. In our people, I don't think it has got any color other than the color of the patient himself. The classic histological findings in inflammatory breast cancer on biopsy is dermal lymphatic invasion by tumor cells in villi, which are responsible for both the local signs and symptoms and the propensity for metastasis. And diagnosis depends on the clinical presentation, as we mentioned before, plus 5-year disease-free rates survival in patients treated with neoadjuvant chemotherapy followed by surgery and radiation range from 22 to 48, and overall survival from 30 to 70%. Approximately 30% of patients with inflammatory breast cancer are regular stage 4 are alive and free of disease at 20 years follow-up. Relapse rates are very high after breast conserving, and these patients are usually advised to undergo, as we mentioned before, mastectomy followed by chest wall radiotherapy after neoadjuvant. In the past, actually, these patients, we cannot operate on them because the tumor is so big, and if you want to remove it all, you have to go very far away from the tumor and leave a very big gap in the form of an ulcer. You cannot close it after that. And we usually try to remove part of the tumor to facilitate closure of the skin to improve the quality of life. And it soon comes back, and we wait for him or her to die without anything. There is a question, does complete clinical response after neoadjuvant therapy, does it need surgery if we give a patient neoadjuvant and the tumor disappeared completely, clinically and radiologically? Is there any need for surgery? Now studies are going on and trials are going to try both and follow them both. Some advocate no need for surgery and you suffice yourself with only radiation to the chest and the breast. Others say you remove the whole breast and if possible, it is local advanced tumor, and you put a marker to show the site of the tumor. Probably you can do breast conserving surgery. But I think there is, instead of previously, we can't operate on patients. Now, after neoadjuvant chemotherapy, we can either are able to remove the breast definitely, and we can even remove part of it and leave the rest, and the quality of life is better. And even now, we cannot operate at all. And this is really a very magnificent advance in the field of breast. There are some myths or misconceptions, or what do you call or misbeliefs in some patients. Some say that inflammatory cancer is very rare and merely affects black women. I'm so healthy and young. No way I could get this. The fact is, represents up to 5% inflammatory cancer of total breast cancer in the United States. And officially, yes, but not impossible to be affected. If you have symptoms of inflammatory breast cancer, please get to your doctor to see. Another misconception, clean mammogram means there is no breast cancer. Lack of a mass on a mammogram means my breast symptoms can't be inflammatory cancer. The fact is, less than half of inflammatory cancer can be seen on a mammogram, less than half only. And more than a half are not seen. So mammogram, if it's negative, it doesn't exclude inflammatory cancer. My breast cancer is growing fast. It makes sense to have a mastectomy and remove it before it spreads more. Since inflammatory breast cancer affects the skin and is diffused, by definition and diagnosis, it is an inoperable breast cancer. Neoadjuvant chemotherapy is the standard of care for inflammatory breast cancer. And only after a response has been observed should mastectomy be performed. if you see a case of inflammatory breast cancer, you find the edema extending even to the other breast and to the upper abdomen. If you want to do mastectomy without chemotherapy, that means you have to remove all this skin, and definitely you are not going to close it again. So neoadjuvant is a must. Another myth, everything I have read on the internet says it is fatal. My oncologist thinks it is bad too. I have friends who really suffered while taking chemo. I don't want to have those side effects before I die. I will do alternative therapy instead. The fact is, with modern treatment, that is chemo, surgery, and radiation, the outcomes in inflammatory breast cancer have improved. A lot of information on the internet is outdated. Chemotherapy often works well enough to make the breast operable. More than 50% of stage 3 inflammatory breast cancer patients are now living more than 5 years free of disease. Even stage 4 patients are living longer and better lives. A disease may be rare, but hope should not be. I have no family history of breast cancer. Therefore, I am safe. People forget that only 5 to 10% of patients have family history. The majority haven't got that. So that doesn't mean if you haven't got it in your family, you are not going to have it. This is a myth. Articles on the internet say inflammatory breast cancer can be caught early. By definition, inflammatory breast cancer is diagnosed at stage 3 or 4. It's usually late. This red rash on my chest wall breast can't be inflammatory. I have breast cancer before. There are 2 types, inflammatory breast cancer. Most inflammatory breast cancer is primary because it arises in a previously normal breast. Some inflammatory breast cancer is called secondary if it arises in a breast with a previous breast cancer, such as a reconstructed breast or in the remaining breast tissue after lumpectomy. If you, however, see proven invasive breast cancer with inflammatory breast cancer symptoms, then you have a clinical diagnosis of inflammatory breast cancer. I had a complete response to chemo. I don't need radiation. I heard you get bad burns and you have to go every day for 6 weeks. Radiation is a critical component of inflammatory breast cancer care. Its job is to kill microscopic disease, the surgeons left behind to decrease the risk of recurrence. While daily radiation appointments are tiring and your skin will be burnt, it does improve quickly, and the temporary period of planning your life around radiation is worth to receive the optimal treatment. Myth number 9, other breast cancer patients have expanders placed at mastectomy to begin their reconstruction. Is inflammatory breast cancer is too fatal to have reconstruction? Inflammatory breast cancer, you cannot use expanders because usually the skin is deficient. You remove a lot of skin and you cannot expand it. Secondly, you need radiation, which will weaken the skin, and the expander usually need constant filling to attain the size of the breast you want. So implants are not advisable in repair in mammoplasty. Mammoplasty is done by muscle latissimus dorsi mobilization after 2 years and after making sure that there is no recurrence at the site of the what is inflammatory breast cancer? We talked about that. There are 5 of the most common myths, another myth about it, اللي هم خزعبلات, if I can tell. Unlike other types of breast cancer, inflammatory breast cancer may be present without a lump. This is mentioned before. Symptoms are often misdiagnosed as an infection known as mastitis, treated with antibiotics. If you do not respond, you have to see your doctor. There is very effective treatment now for inflammatory breast cancer, and actually the mass may disappear completely, and the signs in the chest may disappear completely, and still you have to remove the breast inflammatory breast cancer. you can still have reconstruction after 2 years, as I said, after making sure that there is no recurrence, and after taking the radiotherapy, you can do it. And usually the preferred type of reconstruction is autologous muscle mammoplasty. Research is going on, and although a lot of developments occurred in the line of treatment of breast cancer and in ways of diagnosis, but still the last chapter is not written. And I'm sure the future is for nuclear medicine to adopt and invent drugs which will be targeted towards the diseased cells only, and definitely the future is very bright. Nowadays, we are seeing a lot of locally advanced and even metastatic patients living for more than 10 and 15 years. And so you have to give hope to your patients and tell them there is no despair. And what seems to be advanced in some patients, they may respond better than those who look and present with early disease. As we mentioned later, the disease is different, and although everything is the same, but the response to treatment is usually different. I hope that I made some points of benefit for you, hoping we meet in some other lectures. Thank you very much.
شكرا جزيلا يا بروفيسور على المحاضرة القيمة. نرحب بكل الحضور، بروفيسور رشيد أحمد عبد الله، بروفيسور سليمان حسين،
شكرا.
كل الحضور. أي زول عنده استفسار ممكن.
سيدي وصلت لناس؟
كل الناس حاضرين يا بروف، كل الناس حاضرين هسي
أسئلة؟
وممكن نسمع أي مداخلات وأسئلة.
أيوة.
اتفضل يا مستر أحمد الفاتح.
يس تفضل.
السلام عليكم.
عليكم السلام.
شكرا جزيلا بروفيسور احمد الامين الشيخ. حقيقه I have the pleasure to be one of the registrars in your unit several years ago in Medani. Indeed, few comments and a question. The comments for the registrars. Comments about the locally advanced breast cancer. The decision for the treatment, either the patient to go for surgery or to go for chemo or to have a hormonal treatment, really depends on the fact that the patient should be discussed in a multidisciplinary team. This is very important.
Yes.
Every patient with breast lump, breast cancer, suspicious breast lump, this is very crucial and important point in the decision. For the sake of the patient, please don't take the decision alone. Always try to invite colleagues from the oncology, from the radiology, from the pathology to discuss together what is the best thing to do for the patient. This is the first comment. The second thing, also one of the features of locally advanced breast cancer is that sometimes you find a small breast tumor, but you find a big lymph node, a bulky lymph node. Bulky lymph node is a feature also of locally advanced breast cancer, and that should be taken in mind. And even if the breast tumor is less than T3, if it is 2 centimeters, for example, but the lymph node is 3 centimeters, this is also a feature of locally advanced breast cancer. And in that case, if you send the patient for chemo, the tumor might disappear. And in this case, you should consider putting a marker, a radio-obeyed marker. It is present in Sudan, but it is not readily available in many places. The third thing I want to ask Professor Ahmad a question about if the patient presents with bilateral breast cancer. And in one breast, there are features of locally advanced breast cancer. And in the other breast, there is early breast cancer, T1, T2 with N1 or N0. What is the best treatment in that case? Do we go for chemo first, or do we treat each breast separately? Thank you.
Thank you very much. First of all, if you heard the lecture from the beginning, I mentioned first what we mean by locally advanced, and I mentioned that it depends on the TNM system, in which involve the tumor and the lymph nodes. And I said that part of the locally advanced tumor is due to big lymph nodes in the regional area. So that is mentioned actually during the lecture, and we added other things, satellites beside the tumor. Even if the tumor is small, this is considered locally advanced tumor. Luckily, if you don't know, we have got a combined multidisciplinary clinic since 1998 in Medellin. And we actually, all these cases are discussed every Tuesday after 2 o'clock, at 2 o'clock in a combined clinic, and we negotiate and discuss the best line to take towards the particular patients. So that is catered for actually in our area. For a long time, actually, I think you heard about the combined clinic in Medellin. It started very early and actually attended by oncologists, surgeons, and pathologists, sometimes radiologists with us now, and sometimes plastic surgeons. Actually, it's a complete setup of combined clinic that is catered for definitely in our place. And as I mentioned before, I mentioned at the beginning what we mean by local advance, and part of it is, as you mentioned, lymph nodes, big lymph nodes, 2 and 5 centimeters or more, or fixed lymph nodes, part of advanced disease, even if the tumor is small. I hope I answered your questions.
Welcome, Professor Rashid Ahmad Abdullah.
Can you hear me now?
Pardon?
Can you hear me? Yes.
Ewa?
Can you hear me?
Yes, I am.
Okay. Well, thanks, Ahmad, for this presentation. And I totally agree with you that locally advanced breast cancer don't start as an advanced, it starts as an early breast cancer. And this is a problem, I think. The ratio between patients coming with early breast cancer and advanced, and even those who come with early, early as regard to breast conservation surgery or prognosis. I think the goods that we can sell to the patients is that patients are afraid to come because the thing is that if you come early, we're not going to remove your breast. My second comment about the inflammatory breast cancer, this is really important because it affects, as you said, young patients, and there is a degree of denial from the doctor and the patients that this is not probably a malignancy. And I agree with you that, I mean, you might probably diagnose cellulitis early, probably give him antibiotics, but I mean, it will be very clear in a few weeks that these things are not really a cellulitis. And I totally agree that the clinical picture is important, but I think the biopsy here should be really, what I do is that under local anesthesia, I do a wedge deep resection and then I stitch it. For two reasons, that it gives the pathologist really a good chunk to examine. And the other thing, I mean, the true cut needle in itself now is becoming very expensive.
Yes.
And some of these probably taken by the true cut, they don't take enough. So you need really a good stuff so that you can diagnose the inflammatory breast. The other comment is that going back to how can you actually retrieve patients early? Do you agree with me that breast examination should be part of our teaching for any female coming? I know this is probably not acceptable in Europe, but I think here it deserves that midwives, health assistants, and I mean, whenever a female, I mean, should be examined for above the age of 40 for breast lumps, I think. And I know that, I mean, we are not really capable of doing screening in a proper way, but I think with all these medical schools around and the students around, I think probably in the villages, that can do some probably, and we see how much we can read, because I mean, there is a lot of difference. I mean, when you get this, as you have shown us, this picture is really advanced and very taxing to the patient, to the system. Well, thank you, Ahmad. Really enjoyed your talk.
شكرا يا رشيد يا اخي، الحمد لله سمعت صوتك يا اخي، والله مشتاق لك يا اخي. مش بروفيسور رشيد ولا انا غلطان؟
ايوه هو ذاته. ايوه
يا اخي والله الحمد لله سمعت صوتك يا اخي، شكرا جزيلا لك. باي ذا واي انا والله لايك يو ما قاعد ارسل ناس الانفلاماتوري بريس كانسر لدرو قط ولا بعمل لهم انسجن البايوسي بلوكال في العياده، اشيل لي بلوك ضخمه جدا اديها للباثولوجيست and really it is very useful. Actually I agree with you. يعني we have to adopt ways and means of early detection in the form of some sort of screening, either by doctors at the rural hospital or health centers. But usually there is a problem. A patient who comes to you with a hernia, if you examine her breast, probably she might feel something. She may not feel comfortable.
Yeah.
I think. I mean, the situation is very sensitive. So you have to. Actually, in Wadmadani, we tried to teach some school teachers and some university students from the rural areas how to do breast self-examination, and we made them a course in the oncology hospital for 2 weeks, and with all presentations, and then we send them to their villages because they are females acceptable by their society. And actually, we used to go on our own every other Friday or Saturday to see them there. And actually, we detected a lot of early cases by, I think, encouraging breast self-examination or teaching those females who have got access to their female relatives in their villages. That will definitely. We did it in a very big area, in a Managil area, and we did it in Wadmani itself, and we tried to do it in other actually محافظات في Gezira. Unfortunately, we didn't find cooperation from the health authorities and political parties there, and we stopped doing that. Although we did it on our own, and really, it is very useful, I think. Better, and that's the only way to detect not only inflammatory breast cancer, all cancer actually can be detected by routine clinical examination or by breast self-examination if you can teach people. Actually, there is a question the doctor before you about bilateral breast cancer. If I've got locally advanced and an early breast cancer, I think we had cases like these, and we usually give them the neoadjuvant. The early one will not get harmed, definitely it will improve, and the locally advanced will be amenable to surgery. And then we had 2-3 cases like this of bilateral. So having an early cancer in the other breast does not prevent you from using neoadjuvant chemotherapy, and probably it will make the other swelling in the operable breast smaller and better and easily managed.
I think also selling the idea that if you come early, you don't remove your breast, because even educated females I had, and they come with a big lump, and the whole thing is that the concept that if you come with a breast lump, they are going to have your breast out. So I think we have to sell this that, I mean, it's not always we need to remove the breast. I mean, and this is really the concern, because educated patients coming with big lumps and get surprised about these things.
Yes. It's a misconception. Breast cancer means to many patients mastectomy, unfortunately. I agree.
مرحب بروفيسور سليمان حسين.
مرحبا بك. Yes, معك.
بروفيسور سليمان حسين، you're welcome.
مرحبا بك. معي منو؟
شكله في مشكلة في الشبكة يا برو.
أنا سامعك.
محمد علي عندك سؤال ممكن؟ اتفضل يا بروف، اتفضل بروف سليمان. بروف سليمان سامعنا؟ الو
الو الو الو
شكله في الشبكه كعبه بس بتاع بروف سليمان حسين. دكتور
انا
محمد علي
سامع.
عندك سؤال؟ دكتور محمد علي تفضل اسال، عندك سؤال؟
السلام عليكم بروفيسور احمد.
الو
الله يخليك. انا ريسيرجن سيرجري في last year وكده. I have few questions, 2-3 questions. My first question, as we know إنه ال guidelines وكل ال protocols في ال classification of early breast cancer, locally advanced breast cancer and late هسي now is going to change، خصوصا في الناس اللي هو في حته في النص كده فيها اشكاليه وفيها debates between the guidelines، اللي هو الناس اللي بيكونوا stage 3A اللي هو you can consider دايما انه ممكن يكونوا late early breast cancer او early local regional او locally advanced breast cancer. فحتى في الجايدلاينز في التكست بوك وكده يعني they talk according to the policies European American وكده انه يا اخي you can proceed for surgery first then you do adjuvant chemotherapy، وفي ناس بتتكلم عنه Neoadjuvant chemotherapy then surgery. وهسه مع revolution of chemotherapy في اغلب الكانسرز I don't know في البريست هل الحاجه دي applicable ولا لا. اغلب البوليسيز ماشيه towards انه they give Neoadjuvant chemotherapy for whatever the tumor the stage to see the response of the tumor to the chemotherapy first. بعدين to do the surgery then adjuvant they combine them. انت what do you think في الحته دي خصوصا في stage 3A patients لانه هي حته كده، مع انه في السودان هنا يعني we know انه والله الاكسس to the patient to the hospitals المشكله في الزره في انك انت تمشي وتلقى الصف طويل وكده. ما اعرف في ناس بيتكلموا عنه they better to do surgery هنا في السودان first then adjuvant chemotherapy عشان not to lose the patient، لانه الغالبيه العظمى من البيشنت هنا لو مثلا حصل له complete response to the chemotherapy they might not come. ده السؤال الاول.
yes.
بالنسبه للسؤال الثاني patient لو جاء يعني if we have patient we did mastectomy and axillary clearance و intraoperative we find that level 3 is positive lymph nodes and axillary clearance level 3. Do you combine radiotherapy to the axilla with the axillary clearance or just axillary clearance is enough for those patients?
Okay.
شكرا يا بروف.
Thank you, Ras. First of all, regardless of the stage 3A or any stage of tumor, neoadjuvant is meant to facilitate surgery. So it doesn't these names stage 3A, 3B, B2, C3. It doesn't matter much if I can remove the tumor without neoadjuvant chemotherapy, provided the rest of the breast is all right. I will do it. Sometimes you find T4 tumor, it's local advanced tumor, and I can still remove without neoadjuvant. So it is meant to facilitate surgery. This is the use of the neoadjuvant chemotherapy, regardless of the local advanced disease stage, whether it is 3A or otherwise. This is number 3. Usually, the oncologists they do not recommend doing both axillary clearance and radiation. There are trials trying to take fine needle aspiration from the axilla, and if it is sentinel lymph node, and if they are positive, you give radiation instead of axillary clearance. But the lymphedema very, very great, both of them. If you find sentinel lymph node positive, and then if you don't want to do clearance, you do radiation. The studies up till now showed that the results are the same, whether you give radiation to the axilla or you give you do clearance. But combination of the two is not allowed because lymphedema incidence will be very high. I hope I answered your question.
Can I comment
The
on this?
question here, did I answer your question?
Yes. Thank you.
It's okay. There is a question here in front of me. Do we have screening policy applicable in Sudan? I think we have that. We train personnel in the villages to teach, to examine in their villages, or in every health center and every rural hospital and every hospital, classes are made either in TV or in clubs or everywhere to teach ladies how to examine their breasts and when to start examining their breasts. And by breast self-examination, we may definitely help increase the number of early presentation of breast cancer. I know that the pressure of the hospital will be very great because people get alarmed when they find anything doubtful, but still it is worth it. Yani. We have to teach patients how to examine their breast, or teach personnel to examine ladies at their home and call the doctor or send them to the doctor when they suspect anything. The screening by mammogram is too expensive for a country like us, and probably the prevalence is not as high as in the Western countries to warrant such an expenditure. But breast self-examination, training personnel, I think these are applicable ways of detecting breast cancer early.
Prof. Rashid, تقريبا عندك
Yes,
comment.
yes, I would like to comment on this. Generally, I mean, the guidelines are not really rules, rigid rules. I mean, they are help you to treat the patient. I mean, the request of the wish of the patient and the size of the breast compared to the size of the tumor. And usually, because this lady came to me with a small lump, I think around 2 or 3 centimeters. I was talking about breast conservation surgery. And her husband sitting there said, "This is very good option." She said, "No, remove the whole breast. I don't want it." I mean, so there are other factors that really come to. So the guidelines generally is okay, but I think you have to take in consideration other things, comorbidity, age of the patient, and many other aspects.
I agree.
Mr. محمد الفاتح تفضل. مستر محمد الفاتح تفضل.
السلام عليكم.
عليكم السلام.
Just I have الله يسلمك يا بروف. الله يسلمك. I have another comment about. I have a comment about the use of neoadjuvant chemotherapy. In addition to facilitating surgery, the MDT might sometimes opt for the patient to go for neoadjuvant chemotherapy so as to test the response for chemotherapy, especially in young patients who are expected to have an aggressive disease. In this case, you have the tumor in front of your eyes and you check the response to chemotherapy every 3 cycles or 4 cycles, and you can change the chemotherapy if the patient is not responding. This will not be possible if the tumor is removed before neoadjuvant. So in some special cases, the neoadjuvant chemotherapy is also useful to test the response of the tumor to the given chemo. Thank you.
Agreed. Actually, we mentioned it in the beginning. We said that the aim of neoadjuvant not only to facilitate surgery, but also to test the sensitivity in the future for further chemotherapy. Thank you very much.
We have question, yeah, Prof. Does neoadjuvant improve survival? One of the participants asked this question.
Actually, survival, neoadjuvant, I mean, it improves survival definitely compared with without neoadjuvant. I mean, patients who have got local advanced tumor and with no neoadjuvant, actually, I show a slide showing if you treat them only with surgery without any without any chemotherapy or radiation, the mortality is higher and the survival rate is less. So definitely prolongs. I mean, the percentage of patients who live longer is increased by chemotherapy than without it. I mean, before the advent of chemotherapy, patients used to get the disease advancing, and if you do surgery alone, actually, still, the survival is not good at all. There is a slide actually this lecture showing comparison between the era before neoadjuvant and after, and there is definite difference between the two in favor of another question actually reached out. Does neoadjuvant therapy change the extent of surgical excision? I mean, if decision before neoadjuvant is modified radical mastectomy, can it be changed to breast conversion surgery? The answer is yes. And even nowadays, it may be no surgery at all. May disappear completely, and trials are going on to compare no surgery with surgery after complete clinical and radiological disappearance of the private tumor. There is a slide showing the increased rate of breast conserving surgery after neoadjuvant.
I think this applies also to.
سؤال. اتفضل يا بروف. اتفضل اسف.
Yeah, I think when you have a neoadjuvant and you get disappearance of the tumor, I think this applies to breast and other areas. I mean, even the esophagus, there will be a big question of shall we just wait and see, or shall I mean, this is really a problem.
Yes,
and this question
has been, right?
Yes, and the rest, because medico-legally, I mean, people say if you then operate probably early and there is no tumor found, so where do you stand? I think the answer was that you have to put other factors. The age, if the patient is young or if the patient is old. I mean, there is a lot of argument going on this, as Ahmad has said, that probably work will be going on. How can you really consider neoadjuvant as a definitive treatment, and you don't need to interfere, but you have to have a very close follow-up monitoring of the patient, because this is really very.
I agree. At least in the rectum, Prof. Rashid, in some places now, if the tumor disappeared completely, some people advocate APR or anterior resection, depending upon the level of the tumor, and some think that if it disappeared completely, they follow the patient with repeated MRI and multiple biopsies from the previous site and follow them and see the results. I think there are trials going on concerning the rectum in this respect. And I heard from some oncologists that such trials are going on for breast also in those patients in whom there is a clinical and radiological disappearance of the private tumor.
I want to ask you about the.
I'm not 100% sure.
There is some, I mean, going on that breast cancer affects young patients. I have a lot of reservation about this, because I mean, do really we register the right age? Because in my clinic, I found that there is always a problem, and this is why I usually ask the patient after he comes in to make sure that really he's 50 or 70 or 60, and because I know that, I mean, the Western probably have got aging populations that might probably an effect, but I really have a lot of concern about, do cancer breast really affects young patients?
I agree. I think in our place, the problem is follow-up is not most of the time is not possible. And if you try to do it, they will disappear and they will come with a very bad recurrence and you can't do anything. But probably the Western world, probably this thing is going on. But for us, I think it's better to do the surgery for them because follow-up is usually difficult. You can convince them to undergo surgery after disappearance, which is very difficult. That will be better for them in our place, I think. I agree with you.
Yusuf Ahmad, you are welcome.
Yes.
Welcome, Prof. My question is, if you do a modified radical mastectomy and you send the specimen for histopathology, and there are more than 4 lymph node positive, this is the indication for radiotherapy.
Yes.
So the radiotherapy here will be
It's not
just
clear.
for the breast, will be just for the breast or both for breast and axilla.
يوسف ممكن تعيد سؤالك تاني؟
If you do a
أيوة.
modified radical mastectomy and there is more than 4 lymph node positive, this is an indication for radiotherapy. So this radiation will be just for the breast or for both.
If I find more than 4 lymph nodes involved,
this will be an indication for radiotherapy, right?
Yes.
Okay, this radiotherapy will be just for the breast or both for breast and axilla.
It's not clear.
يوسف ممكن تبسط سؤالك ده تعيده تاني؟ سؤالك البروف قال لك ما واضح.
In the modified radical mastectomy, there is more than 4 lymph node positive. This will be an indication for radiotherapy. This radiotherapy just for the breast or both for breast and axilla, because oncologists say that in the sessions they do radiation for both breast and axilla, and this will be a combination between axillary clearance and radiotherapy.
Yes, I mentioned actually this question has been asked before. Axillary clearance, if you do it, radiation is not recommended. Is not recommended. You can go again if the number of lymph nodes retrieved is small, less than 10. Probably you go again for another axillary dissection rather than give radiation. Radiation and axillary clearance together, the lymphedema incidence is very high. It is not recommended to do radiotherapy after axillary clearance. Either or. Did I answer you?
Yes.
Okay.
Okay.
Mr. Tamer Babikir, you are welcome.
Assalamu alaikum.
Yes.
Thank you, Professor, actually for your presentation. Actually, I have a comment and a question. The first comment is about in regard of the question is in regard of complete radiological response in the form of neoadjuvant chemotherapy. What actually known in the literature that the possibility of recurrence is about 30%, so this is not adopted in any kind of guidelines.
Sorry, your voice is not clear. Again, if you don't mind.
Okay, sir. Just a minute.
Please.
First, the comment is regarding of the patient with a complete radiological response for those who received a neoadjuvant chemotherapy in a locally advanced breast cancer. The risk of recurrence is about 30%. So this is why it's not adopted actually in any kind of guidelines, sir. This is the comment. Now, in regard of the question, sir, just I'm asking about those patients who received the neoadjuvant chemotherapy and they are
I'm not hearing you. للأسف.
are originally having a positive lymph node with the biopsy.
صوتك ما واضح يا دكتور تامر، ما واضح الصوت.
الصوت ما واضح يا دكتور للأسف.
طيب طيب كده كلير؟
أيوه.
طيب sir, the first I don't know if you hear the comment or not.
We heard the comment. You can ask your question.
The question is for those patients with locally advanced breast cancer who are known with a positive lymph node, okay?
Who are known to have what? الصوت مقطع.
Neoadjuvant chemotherapy. معلش أنا آسف. I'm so sorry.
السؤال كان سامعه.
Okay, sir. Thank you. Okay, sir. هكتب السؤال حاضر.
لو في أي زول عنده كومنت ولا سؤال ممكن يسأل.
باين عليه سؤال كويس لكن انا ما سامع كويس.
طيب sir,
هاي
I'm
قال
speaking about the patient who's receiving the neoadjuvant chemotherapy with a positive lymph node before the neoadjuvant chemotherapy in patient with locally advanced breast cancer. After a complete response, shall we do a sentinel lymph node biopsy or axillary dissection?
Huh?
Okay, sir. Okay, sir. I'm so sorry.
Can we do sentinel lymph node or shall we go for the axillary lymph node dissection?
Radiation?
Axillary lymph node dissection, or we can do sentinel lymph node biopsy after complete response regarding lymph node.
Actually, this is a good question. Actually, after neoadjuvant, if the mass disappears and the lymph nodes disappear clinically, is still axillary clearance is advocated. And actually, that will give you, will make you be sure of the response of the tumor. If the number of lymph nodes removed involved, the number involved is great, that means the prognosis is not good. And after neoadjuvant, those who have no lymph nodes involved after neoadjuvant, the survival is far better than those with involved lymph nodes. From 4 to 10, the survival extends from 75 to 20% if more than 10 lymph nodes are involved after neoadjuvant. So axillary clearance is advocated even if no palpable lymph nodes after neoadjuvant. It is a form of assessment for the response actually. Here you see it in the tumor, yes, but you have to remove the lymph nodes and assess them. If the lymph nodes are not involved, that's a very good response, and probably the prognosis is better. If 4 or less lymph nodes are involved, survival is less, and the more the lymph nodes involved are after neoadjuvant, the survival is worse. Any more questions?
Thank you, sir.
Go to sleep, خلاص.
لو ما في أي أسئلة تانية ولا comment, thank you very much Professor Ahmad Alamin Alshaikh for this very nice and informative presentation, and we hope to see you in next presentation. Thank you Professor Rashid Ahmed Abdullah, thank you all of our consultants, all of our colleagues, and we hope good night. Thank you very much.
Thank you. Assalamu alaikum. Very good.